Great. Thumbs up if you can. Yeah. Dr. Elliott, are you ready to start?
I am ready. I think if everyone can mute themselves, I am ready to take off here.
Oh, that's wonderful. Welcome everyone to our meeting today on infectious diseases with a focus on COVID-19. I'm Mary Stebbins and I'm happy to welcome you all. Tim is working fast and furiously on getting some new volunteers organized for us and the schedule out. And so I'm sure he will be joining us later on, hopefully sooner than later. But in any case, I'd be happy to get things started off today. I am delighted to introduce Dr. Sean Elliott. Dr. Elliott earned his MD from Columbia University College of Physicians and Surgeons in 1993, followed by a pediatric residency at Children's Memorial Hospital, Northwestern University School of Medicine, and a fellowship in pediatric infectious diseases at St. Louis Children's Hospital, Washington University School of Medicine. He was recruited to the University of Arizona College of Medicine in 1999 and served in multiple roles there. Professor of Pediatrics, Associate Chair for the Department of Pediatrics, Pediatrics Residency Program Director, Director of Infection Prevention for Banner University Medicine in Tucson, and was Interim Associate Dean of Curricular Affairs for the University of Arizona College of Medicine. Dr. Elliott retired from the University of Arizona after a 20-plus year career and now has returned to his first passion, providing pediatric subspecialty clinical care and teaching at the bedside. However, the COVID-19 pandemic has called him back to the role of content expert and consultant to healthcare systems in Arizona, and he is happy to bring the current state of evidence to this important discussion. He also is personally invested in the ongoing discussion about returning to in-person school, as his life partner is a high school teacher in one of the most under-resourced and high-risk high schools in Arizona. I have to add a personal note. I am especially delighted to have Dr. Elliott with us today to give this important discussion because Dr. Elliott should add to his repertoire that he is one of our illustrious members of the Medical Reserve Corps of Southern Arizona. And I am so delighted to introduce him today for many different reasons, but that's in particular one of them. Thank you, Dr. Elliott.
Thank you so much, Mary. Thanks, everyone. Good morning. Happy Saturday. Today's talk says infectious disease with a focus on COVID-19. It is a primary focus on COVID-19, and I'm going to take the opportunity to go over our current status with the vaccines, as well as current status of the current pandemic. I'd love to start this talk with these two quotes from two prestigious microbiologists from the 1970s, Burnett and White. And it's very tongue-in-cheek, and so they said, and I quote, "The most likely forecast about the future of infectious diseases is that it will be very dull." This was 1972, remember. There is, of course, always a risk of some wholly unexpected emergence of a new and dangerous infectious disease, but nothing of the sort has marked the last 50 years. This was probably one of the most dismissive and now ruefully looked back upon set of quotes, because, of course, shortly after 1972, there was an explosion of epidemics, pandemics, worldwide infections, and you can see a list of those on the left there, as well as it's actually outdated. This is just from 2012, but a CDC chart of all of the current clusters of infectious diseases occurring globally. You will note in the list to the left things such as HIV/AIDS, the first SARS coronavirus, which was back in 2003, 2004, Middle Eastern Respiratory Syndrome virus, Ebola virus. All of us have rueful memories of that. Even the 2009 H1N1 pandemic. Then, of course, what we're currently facing since really fall winter of 2019-20, the COVID-19. So there is much fodder here for microbiologic historians and a whole bunch of chatter on the current internet about what epidemics or what pandemics actually count as catastrophic. Now, you might quibble with their definition of catastrophic. They're looking at an overall impact on human health. And I'll propose to you in just, I think, the next slide, a different way of looking at that. However, historically, there are a whole list of pandemics that did not meet the criteria for being catastrophic, including the most recent 2009 H1N1 influenza A. And I think many in the Medical Reserve Corps remember being part of the response to that. You know, getting vaccine clinics at High Corbett, at Keno, trying to prevent transmission with, again, suggestions of hand hygiene and social distancing. Very similar concepts to what we've been facing now for the last almost year. The 2003 SARS coronavirus 1, which certainly made its way around the globe and was watched with great trepidation. But when all was said and done, here in the States, we had fewer than 80 cases, and they all did quite well. Even the Ebola virus, 2014, which precipitated a significant response, did not meet the criteria for catastrophic or not. And in fact, I'm sure many of us are currently having a little PTSD from fall of 2014 when Mr. Thomas Duncan presented to Texas Health Presbyterian with what ultimately was found to be Ebola virus, infected 2 nurses, and unfortunately died. That single event precipitated a firestorm of concern from the CDC, from every state, and within the matter of, and I kid you not, 72 hours, every healthcare center in the country was directed to create a response to successfully screen, diagnose, isolate, and treat a suspect patient with Ebola virus. In fact, there was such huge hoopla, including geographic disarray. Anybody who had some bizarre limited link even to the whole continent of Africa, it didn't matter, West Africa, East Africa, South Africa, it didn't matter. They came to emergency departments with concerns. They, with a rhinorrhea, a slight nasal congestion, had Ebola virus, to the point where, and I share in the lower left part of the screen, a very tongue-in-cheek perfect screening tool quiz. Do you have Ebola virus? This is what we all wish we could have asked in emergency department triage. And the question is, have you touched the vomit, blood, sweat, saliva, urine, or feces of someone who might have Ebola virus? No, then you don't have Ebola. If only it could have been that easy. But in fact, it was not. And I think many of us in the Medical Reserve Corps were aware of this. When I was at the university, Banner University Medical Center, were directed to and became one of the 51 treatment centers for a suspect Ebola patient, which included, and I was the director of this, a $5.2 million budget for a 5-year response plan, a partnership with Rural Metro and Southwest Ambulance as our EMS first responder partners, multiple live drills, pictures of which you see here, and this huge outpouring of angst and concern, all in anticipation of the suspected horde of Ebola patients coming into this country from West Africa. When all was said and done, I think we all know the numbers. As devastating as the outbreak was in West Africa, and tens of thousands of deaths, a 50 to 70% mortality rate, a death rate, highly infectious among populations exposed to the body fluids of Ebola patients. Yet in this country, our numbers were tiny. We had suspect patients. In fact, many may not realize this, but we actually did activate to assess a suspect patient. It was a Sunday morning, a 14-year-old who had traveled from Monrovia, Liberia, to this country, promptly developed fevers, and in conjunction with Dr. Garcia of Pima County Health Department, quarantined in apartment. And unfortunately, on day 3 of her febrile illness, she developed vomiting, diarrhea, and the CDC directed us to activate our assessment and treatment center. So on a Sunday morning at 7 a.m., I brought her into Banner UMC Emergency Department. We closed down the ambulance bay. Nobody else knew what we were doing. It was felt to be another drill. And my infection prevention nurse and I donned our full tier PPE, assessed her for 3 hours, confirmed that she had malaria, not Ebola virus, sent her home with treatment in hand. Nobody knew about it, which is fantastic. That was actually the CDC has sent to the Arizona Department of Health Services a formal recognition of the ease and smoothness with which we conducted that assessment. Whereas the same weekend, same day, in fact, in Birmingham, Alabama, University of Alabama, Birmingham, assessed a patient who too had malaria. But they activated the SWAT team, and they activated campus security and the fire department, and that patient's name was splashed publicly across the media, and that patient was run out of town with death threats. So this huge, I share this story just to highlight the huge hoopla, which even the threat of a possible global infection posed to this country, which meant we were all dressed up, ready to go, and honestly, nothing happened. So that, I think, is behind this slide. Again, very tongue-in-cheek. Huge response, tons of effort involved in responding to that, and nothing happened. So what happened this time? Here we are with another global threat, another infectious disease, again coming from a part of a country in another part of the world, this one being Wuhan, China. And we, pardon the euphemism, were caught with our pants down. Nothing happened. So I would propose to you that this sort of played out in real time, and the amount of preparation and perhaps overkill for the Ebola response may have negatively affected our response to this. So here's where it all started. COVID-19, the early days. So December, actually even November 2019, patients with a upper respiratory tract infection, which progressed rapidly to a lower respiratory tract infection, started to present to clinical centers in the Wuhan province in China in that late fall, early winter of 2019. As the numbers started to eclipse what was felt to be normal for that time of year, additional concern was expressed. Indeed, whistleblowers in the medical community declared a medical emergency and were rapidly shut down by governmental response. Ultimately, and I think we all know this history, finally, by March 11th of 2020, when cases had begun to surface elsewhere in the World Health Organization declared a pandemic. The initial Wuhan experience, and this has been reported extensively, was just 72,000 patients, almost all of whom had mild disease. There were indeed 5% who had critical illness, with a mortality rate of around 2.3%. Even then, the risk factors, which we know today to be true, began to emerge. Age older than 60 years old, presence of coronary vascular disease or hypertension, obesity, underlying diabetes, underlying renal dysfunction. So this is where it all started. And ultimately, the infectivity was found to be around 12%, meaning index patient in a family setting or a closed space community setting, there's a 12% risk of individuals around the index case becoming infected. That is quite significant. Both the mortality and the infectivity far eclipse that normally seen with the annual influenza A and influenza B epidemic. So here you have two sort of point spread charts. The top one is for 2 months from that December 2019 to early February of 2020. The second one is late February to late April 2020. And you can see an explosion of cases coming from point sources going all over the world. This absolutely is what developed into what we now know as COVID-19 today. So where are we at today? Now, these numbers come to us from the Johns Hopkins Review site, I guess. Hopefully most of us have access to that. Globally, now over 93 million cases, and announced just this morning, we have now eclipsed 2 million fatalities since the start of the COVID-19 pandemic worldwide. In the United States, we are over 23 million cases. Somebody could mute, please. We're getting a bit of an echo. That's right. Everyone check your phones, check your computer. Hey, there we go. Perfect. Thank you. So over 23 million cases here in the States. This number, 386,577, is from 2 days ago. So we are now actually closer to 400,000 dead. This is what I think that the pandemic has come, and this actually has historic precedence from back in the days of the Black Death or the bubonic plague, and much was written about that too. In fact, again, the medical historians can sort of couch a catastrophic pandemic such as this one into a 3-act play. Act 1 is all about ignorance or perhaps denial. And that certainly occurred in this state. You know, we thought, okay, well, what's happening in China is going to stay in China. What we learned from Ebola, what we learned even from the first SARS coronavirus, is that there may be some global cases, but they will be few, insignificant, and here's the important part, we can handle them without committing significant financial resources to ramp up our response. That, I think, is the negative teaching, which unfortunately we learned from Ebola 2014. So Act 1 is ignorance/denial. Act 2 is awareness. Awareness, like, holy Toledo, those cases starting in the West Coast are now getting all over the United States, and golly, they're sick. What happened? Oh, that evil, terrible China. So Act 2, the awareness, is not a positive, it's a negative. Like, the virus has the audacity to cause disease in our country. Our advanced medical care can handle anything country. We have all the resources of the world, and yet these patients still keep getting sick. In there too, of course, is going to be the finger pointing, and as I think many of you are aware, there was significant rhetoric between this country and China and even other parts of Europe for allowing this pandemic to get out of control. And that rhetoric was followed by financial disincentives, and as we all know, that this was a rabid response from this country and others about the point of origin. To the point, in fact, where, and this is sorry to say, but many Chinese businesses were shunned and forced to close. This happened during one of the earlier influenza pandemics, which was felt to come from China as well. So that's Act 2, awareness. Act 3 then is response. And this act can go one of two ways. Either the country of origin, in this case the states, can ramp up its response effectively and in a timely fashion, get on top of the outbreak, prevent further clusters from occurring, and have a successful conclusion. Or, and this is option 2, that doesn't happen through a combination of denial, history, experience, lack of resources, personal, meaning public response, i.e. Mask non-wearers, people who disbelieve the vaccines, etc. And in that case, the expected potential outcome is a 50% mortality, meaning that country has the potential to lose up to half of its population. Now, hopefully, this country is, I mean, obviously we're not on option 1 because we have our challenges in ramping up in time, and we currently have the leading attack rate, mortality rates, and negative outcomes of the world. But also, too, I would like to think that due to the efforts of volunteerism and the CDC and science, that we're not going to realize option 2. So I guess what remains to be seen is how far between those two options we are going to land. And a large part of it has to do with ongoing vaccine efforts and, of course, the volunteerism of organizations like Medical Reserve Corps, everybody else who's stepped up through the state and the county health departments. So along with those 3 acts, we all love to talk about themes or threads is what we talk about in medical education. And the 3 themes through the whole thing have been blame, failure of intervention, i.e. personal responsibility, and stigma. Why, and I assume we've all seen this too. People who suffer stigma for either wearing a mask and are ridiculed for being nervous Nellies, or are ridiculed and stigmatized for not wearing a mask. So the country is experiencing, unfortunately, in real time, all these well played out dramas that have occurred time and time again. And I will quote this oft-used adage: if we fail to learn from our history, then we are doomed to repeat it. So with that, let's go into clinical aspects of the virus, and then we'll go to the vaccines and what we can do, and especially issues involving what we can do to try and intervene more successfully. So this is the current understanding of transmission possibilities for the SARS coronavirus 2 as it causes the disease known as COVID-19. Primarily, this is still a droplet, a large respiratory droplet transmission, such as we see with rhinovirus, the cause of the common cold, such as in pediatrics, we see in respiratory syncytial virus, the cause of normally severe bronchiolitis in babies and children. But with SARS coronavirus, it's a large droplet, which means that upon expression, either through coughing, sneezing, deep breathing, singing, shouting, some sort of process by which the airways expel air at higher than the normal velocity, those droplets can travel for about 3 feet. Yes, 3 feet or 1 meter from the point of origin, from the mouth to the nose. At that time, though, gravity ensues and they settle down onto horizontal surfaces. There, fortunately, they are relatively short-lived. So the initial concerns about groceries and mail and countertops and toilet seats, etc., being points of contact for the coronavirus have been found to be not true. And simply, or luckily, a simple cleaning even further abrogates that risk. So that's fantastic. That is the primary mechanism of transmission. However, it is also true that those same droplets can be aerosolized in much smaller particles. So here we're talking well under 5 microns or 5 micrometers in diameter. These are aerosolized particles such as transmit tuberculosis, varicella, the cause of chickenpox. And these aerosol droplets can live in the air and suspend in the air for well more than the 3 feet or the 1 meter distance. In fact, studies have shown they can travel and be contagious in up to 12 feet. So this, of course, this evidence came through after the initial clusters, and in retrospect, likely contribute to the ease with which this virus transmits within community settings, within small group settings, restaurants, gyms, et cetera, and so forth. And then the final potential for transmission has to do with urine, feces, and other body fluids. Not as much the fecal oral spread that we see with food poisoning, for example, such as Shigella or Salmonella, but more if either of those themselves is aerosolized. Because the virus can be transmitted into any body fluid, saliva, urine, feces, blood, etc. If that body fluid then is aerosolized for whatever reason, let's say, not to be gross, at 9:25 in the morning, but explosive diarrhea, that indeed can aerosolize and create a mist of infectious enteric particles, very much as we see with Clostridium difficile, with C. diff. And in fact, this has been proven in hospital settings that C. diff can create this infectious miasma or mist in a patient's room, to which healthcare providers can be exposed as they enter in without a mask. So all these ultimately have to transmit disease by gaining access somehow to the susceptible host airway, either by being breathed in or inhaled through the nose. Very unlikely to put hand to mouth and transmit the disease that way. So again, the evidence is against those environmental sources, groceries, mail, packages, etc., of being a true transmittal. Instead, it's anything which can aerosolize and get past the barrier of the nose and the mouth. And again, proof positive why the mask is such the most effective intervention possible. So what does normal COVID-19 look like? Again, a majority of patients, and again, up to 80% experience this, have mild disease and or are asymptomatic. The mild disease typically is now presenting with the sort of the onset, oh, I think I'm getting sick. Usually that's muscle aches, the feeling of malaise, followed by the fevers. Shortness of breath and difficulty breathing are quite prominent in patients who are symptomatic with the disease. The anosmia, that's the loss of a sense of smell and subsequent loss of sense of taste. This is quite prominent in at least a third of patients, and perhaps even more, if one were to do a complete population study. These symptoms develop typically over an incubation period of from 2 to 14 days. Very much the common incubation period is 4 to 5 days, which actually is important because that informs our current approach to isolating patients who may have been exposed to disease. And that typically is going to be 7 to 10 days if they have negative testing. The length of symptoms of overt active symptoms, meaning fevers, myalgias, the muscle aches, the anosmia, is at least 3 to 14 days. Many, however, are experiencing a post-infectious prolongation of their symptoms, the so-called post-COVID-19 syndrome. And these patients especially are commenting on fatigue and the COVID foggy brain as their most prominent findings, along with, unfortunately, that anosmia. So there are many who personally sharing their anecdotes 2 to 3 months after their known infection still cannot taste in any great way. Or if they do taste, what they're tasting is unusual. That there's something called parosmia, P-A-R-O-S-M-I-A, which, as it turns out, is becoming increasingly common, even more so than the total lack of sense of smell. The patients with parosmia are smelling odors of rotten fish and sulfur and burning materials. And those senses are quite prominent. And not surprisingly, they have a negative effect on one's appetite. So the post-COVID-19 syndrome is lasting well over weeks to months. And in fact, there are what are called now the long haulers that are still 6 months after infection, still dealing with significant fatigue and the foggy brain. What is foggy brain? It actually is a very specific cognitive dysfunction akin to short-term memory loss. So, not surprisingly, first responders in the audience may have seen an uptick in calls for house fires. Calls for first, second, and third degree burns from hand on stove, having forgotten that I left the stove on to cook lunch earlier yesterday. Making sort of dangerous decisions just based on forgetfulness, like I forgot I left that active fire going, or the candle burning in the bathroom. So there's that. There's also confusion, loss of direction, getting lost. So a whole bunch of people experiencing what is being called an acute onset short-term Alzheimer's. That is huge because it doesn't go away right away, and the numbers of resources available to help people navigate their fatigue, their loss of productivity, their loss of focus. This is another pandemic which has yet to be realized, and I think our primary care providers and a whole bunch of people in mental health fields have yet to be thoroughly stressed by this as we go further into the pandemic. Other post-COVID syndrome findings, exercise intolerance, that absolutely has to do with the dyspnea, the difficulty breathing. In fact, one of our surgeons, who is a COVID survivor, tried to go up a set of stairs. And this person is incredibly robust. Like I would not want to face off against them on a football field for sure. But lost their breath going up one flight of stairs and had to stop and rest for 30 minutes. So that's significant. The impact of cardiomyopathy, of cardiac disease. Initially, there was a huge concern that 2/3 of COVID survivors had or would have some degree of myocarditis, of inflammation of the heart. Fortunately, the studies demonstrating that had a huge selection bias. So in reality, it's less, which is good, but it's not zero. So estimates now from 3 to 10% of people who have had COVID-19 have some degree of heart dysfunction, which contributes to their exercise intolerance. And of course, along with this, any sort of chronic illness is going to be accompanied by anorexia, weight loss, deconditioning, the whole 9 yards. So this is a very big deal, which I personally think is the pandemic after the pandemic. What about those patients who have severe disease? And of course, these are the ones who get all the press because they're the ones who are needing and taking up medical care, hospital, ICU resources. So the typical person with severe or critical COVID-19 indeed is an older individual and or a young adult, both of whom will have significant comorbidities. And you see them listed there. The three most common: obesity, hypertension, diabetes. And unfortunately, all those three co-migrate, meaning somebody who has obesity is very likely to also have, adult onset diabetes and hypertension and or poorly controlled other health issues. Typically, these patients are presenting already with an oxygen requirement, meaning their peripheral oxygenation is under 93%. And in that setting, they may rapidly progress to have adult onset or acute onset respiratory distress syndrome, ARDS. Along with that, multi-organ dysfunction, and here we're talking liver, kidneys, bone marrow. They're developing low white blood cell counts, low platelets. They're coagulopathic, meaning they're stroking and having bleeding events. And then ultimately, the final cause of death is cardiogenic shock, which is refractory even to all the medications we have normally to treat that. So patients who go down this pathway, depending on where they live, the amount of resources available to them, and on their comorbidities and age, have up to an over 10% risk of death. This is huge. Even the 0.3% mortality estimate in well-developed countries with lots of support systems, that's 3 times higher than the anticipated mortality from influenza, which, by the way, kills 60,000 people in this country every year. So this is a big deal. It is no surprise at all, as Arizona is in the middle of its now 3rd surge, that we're down to numbering the available ICU beds on the fingers of 2 hands. Kid you not. So this is a very big deal. So what are our interventions? What are our resources to treat, to intervene? And obviously the best intervention is prevention, and we'll get to the vaccines in the next slides. But what we currently have as treatment, based on all the evidence available, is the antiviral drug remdesivir. This drug acts to prevent binding and injection of the nuclear material of the coronavirus into its target epithelial cells. That drug specifically in this country remains approved by the FDA after emergency use authorization, and it is a standard of care for patients who have severe or critical disease, meaning coming into hospital, having an oxygen requirement, requiring some advanced level of respiratory care, be that high flow nasocannula oxygen or intubation ventilation. I'm spending some time talking about the impact of remdesivir because the World Health Organization, in a multi-country, multi-center trial, did not find that remdesivir had any meaningful impact on outcomes. Unfortunately, the studies, I should say, performed by the WHO and published suffer from a wide array of methods and recruitment strategies. And so methodologically, from an evidence-based perspective, the studies are not sufficiently powered to give that answer. Yet they're being held by WHO as a reason to not advise use of remdesivir. In this country, local studies in the states and an exhaustive review of the literature by the Food and Drug Administration, by the CDC, by infectious disease societies for that matter, all find there to be a positive impact of remdesivir on the mortality and on the length of hospitalization of patients with severe to critical COVID-19. How significant that benefit is truly depends on how sick the patient is when they first present. So those who come in and rapidly progress to intubation ventilation stand to experience the best benefit, the greatest benefit. And here we're talking a clinical improvement of 30%. 30%. That's significant. Perhaps even more significant then is the impact of dexamethasone. Now, once again, this is not true for all players with COVID-19. Those who are the sickest, who, as it likely is, have the most significant likelihood of an immune-mediated component of their disease. So it's not just COVID-19 itself caused by the coronavirus, but it's the immune reaction to the coronavirus infection, which is causing the multi-organ dysfunction, the respiratory failure, the dyspnea, the shock. Those are patients who stand to benefit from an anti-inflammatory drug such as dexamethasone, which is a high potency steroid. So indeed, in those patients who meet criteria, respiratory failure, needing oxygen delivery by high flow nasal cannula, certainly low peripheral oxygenation, those patients all have and continue to experience benefit from dexamethasone. Importantly, they require up to a 10-day course of dexamethasone. If they improve prior to that, then the steroid can be tapered off. But this is a significant intervention. Other interventions, and again, a lot of these have received a lot of scientific press recently, other steroids. It stands to reason that if dexamethasone works, so too should other injected steroids, so too should other oral medium and high potency steroids. The key though is the potency and the length of treatment. So for example, patients who have known asthma, who come in with COVID-19 have an oxygen requirement, normally with an asthma exacerbation, they would be given a 5-day burst, we call it, of oral prednisone or prednisolone. That is ineffective or insufficient to convey a significant impact on their outcome from COVID-19. So instead, those asthmatics are requiring higher doses of their prednisone for longer. But again, they are still experiencing benefit. Convalescent plasma. So this would be taking immunoglobulins, especially IgG, from survivors of COVID-19, pooling them, purifying them, and then administering them to a patient who's actively infected with COVID-19. The thought being that we're sort of boosting the immune response of the active COVID-19 patient. Theoretically, it sounds fantastic, and in reality, unfortunately, the impact has been not fantastic. Multiple studies, multiple large studies, have failed to demonstrate any significant impact on outcomes, mortality, death rates, length of hospitalizations, length of ICU stay, except until 3 days ago, when finally a study looking only at convalescent plasma from patients with high titers, meaning they had a rip-roaring COVID-19 disease themselves, have super high amounts of immunoglobulin G in their blood, which is purified. So here again, it's a matter of degree. The higher the amount of COVID-19 or SARS coronavirus specific immunoglobulin G that is purified and then administered to a new patient, the better the outcome. So that ship is not yet dead in the water. I think we can see more science coming through, hopefully in the near future. And then, of course, the big one, which is huge right now, this is the monoclonal antibody cocktails, either from Regeneron or from Eli Lilly, both of which, those products, have multiple millions of doses, have been purchased by the federal government and distributed to hospitals around the country, and are currently being administered in infusion centers around the country. And in fact, the infusion center at Tucson Medical Center is right across the hallway from my office. It's currently staffed by federal response medical personnel from HHS, and they are infusing up to 30 people a day. Who qualifies for the monoclonal antibody treatment? Those patients who are infected but not yet severely symptomatic. And the reason for that is that the studies looked at patients who had already developed symptomatic, meaning severe disease, an oxygen requirement, respiratory failure. And in those patients, unfortunately, there is limited to no benefit. On the other hand, patients who have risk factors, so an age cutoff, so age 60 and older, who have underlying chronic lung disease, obesity, diabetes, all those comorbidities I mentioned before, these are all individuals that are benefiting from prophylactic use or empiric use of the monoclonal antibodies to prevent progression of their disease. This is huge. If we can prevent 30 people a day at one center from requiring an ICU bed, that's going to free up beds for all the others who maybe got too sick too quickly and could not benefit from the monoclonal antibody. So there is definite benefit from that. I expect we can see further evidence coming down the pipeline to support further growth of such products, including maybe even more than just 2 monoclonal antibodies put into that product itself. I mentioned here on the slide hydroxychloroquine and ivermectin as two sort of anti-parasitics or anti-malarials. For hydroxychloroquine, there has been a robust amount of science, both in this country as well as globally, looking at theoretic impact of each of these products. And to date, there has been no discernible proven medical benefit in any indication, whether it's prophylactic, whether it's treatment of a severely ill patient, and at different doses as well. That hasn't stopped many people out of desperation with nothing else to use from using these medications. But at least the scientific evidence is not supportive of their ongoing use. So, as promised, the best intervention is prevention, and here are the current vaccine products, and we'll talk about each of these categories a little bit more in detail. So the current two vaccines available for injection, and as we have been injecting in our infusion clinics or shot clinics, are the messenger RNA vaccine products, Moderna and Pfizer. Coming soon down the pipeline are the adenovirus vectored vaccines, AstraZeneca and Janssen Pharmaceutical. That's the pharmaceutical subsidiary of Johnson & Johnson. Also newly being tested in phase 3 trials are spike protein nanoparticle vaccines from Novavax. There's the Russian vaccine, Sputnik 5, which is also an adenovirus vectored vaccine. A lot of work now on live attenuated vaccines, virus vaccines and polysaccharide vaccines, similar to what we experienced with tetanus, et cetera. And then also a work occurring currently in the United Kingdom and China with intranasal vaccines. And this last category, the intranasal vaccines, to my mind, has the greatest potential to have meaningful impact on the pandemic. Here's why. All the other vaccines are injected, all right, makes sense, and they are helping the human being create an antibody response against the virus after infection has already occurred. So what those vaccines are likely to do is to prevent, or hopefully prevent, escalation to severe disease and hopefully development of clinically symptomatic disease. But they have no ability to prevent binding of the virus to the nasal epithelium, to the passages where the virus normally binds. So anybody who has received an injected vaccine is still going to be potentially contagious to others who are not vaccine protected. That's why we're still wearing our masks, even those of us who've been immunized, because we could still bind SARS-CoV-2 to our noses, go home, sneeze them out, and transmit them to somebody at home. The intranasal vaccines actually are, again, going to intervene not just with development of infection, but with binding, period. So they are going to coat or prevent and bind out those nasal epithelial cell binding sites for the virus and prevent binding at all. So it's kind of like a total shields up, to use the Star Trek analogy, so the weapons can't get in, the virus cannot get in. To my mind, if we wish to intervene with the ongoing contagiousness which is driving the pandemic, that's a great way to do it. So let's talk more specifically about the categories of vaccines, just to understand what they're doing and how they're doing what they're doing. So the messenger RNA vaccines, again, Pfizer and Moderna are the two. Even despite the name, people hear like, oh, RNA or DNA, and there's a concern that will be creating mutant humans, like the zombie apocalypse, running around the streets of Tucson and Arizona. No, that's not true. These are completely inert pools of messenger RNA, which injects into the muscle, where the messenger RNA is eaten or taken up by an antigen-presenting cell. This is a normal immune response to foreign antigen. In this case, the messenger RNA is the foreign component, but as it is taken up by that antigen-presenting cell, it's able to in the cytoplasm, be converted using cellular machinery into the spike protein. Now, the messenger RNA is only for the spike protein. It's not other elements of the SARS coronavirus. There is zero way that we could create an infectious viral particle by injecting that vaccine. And I'm being very clear about this only because questions of this nature have come up from many of the general public. And as we gear up to hopefully eventually vaccinate the general public, they need the reassurance through our answering their questions that this is a safe vaccine to use. Other elements of its safety. The messenger RNA that's injected is rapidly degraded by those same immune cells over the period of hours to at most 2 days, so that there is no messenger RNA available to run through the bloodstream, to go to the nose, to be contagious, and it's not contagious because it's not virus. And similarly, it is safe for those who are pregnant, for those who are nursing, for those who are wishing to get pregnant, all three of which are very strong areas of concern among many of our healthcare providers. Both vaccines are a 2-injection series, as we know, since we are currently doing round 2 for the first recipients. Pfizer's vaccine is spaced by 3 days, plus or minus 4, by 3 weeks, plus or minus 4 days. Moderna's is spaced by 4 weeks, again with a 4-day window. Both have shown efficacy, meaning prevention of infection, of 95% or 94.5%, I'm rounding up. And both have shown 100% protection against development of severe disease should the patient get sick. And in fact, we've already seen that even after the first injection. So both are highly efficacious, far exceeded everyone's wildest hopes and dreams, and that's fantastic. Side effects, yes, there's a whole bunch of popular press, and I guess I've contributed to that, that indeed the injection sites are a little tender, both, and especially after the second injection, but some after the first, have experienced a flu-like illness. So low-grade fevers, the chills, the muscle aches, the fatigue, and those who are experiencing those are experiencing them for 1 to 2 days. Of course, as you could imagine, once we start immunizing the general public, the degree of those side effects, I think, is going to it's going to gain some traction, I think, on social media, and I imagine that there will be those who are nervous about willingly getting an injection, which is going to cause them to feel like garbage for 2 days. However, my answer to that is: do you want to feel like garbage for 2 days, or for 2 to 3 weeks, lose your sense of smell, and then die? You know, it's a simple comparison, right? And sorry to be blunt about that, but I think we're going to need we will need to be very clear about tolerating the side effects, which truly are mild to moderate, versus the risk of getting sick with COVID-19, or more importantly, conveying it to somebody else who could die from it. So those are the messenger RNA vaccines. The next category are what are called the vectored vaccines. A vector is an environmental and organic something which serves as a carrier for the actual response, the actual infection. So in this case, the vector is an adenovirus. Adenovirus is a respiratory virus. It causes human disease. And you might think, why in the world am I giving protection against COVID-19 by giving somebody another respiratory injection, a respiratory virus injection? That's ridiculous. However, the adenoviruses used, and there are a different range depending on the products, are either attenuated so that they cannot cause, attenuated meaning modified, they're modified so they cannot cause human disease, or that they come from a type of adenovirus which does not have tropism, meaning specificity for humans. So, for example, in the AstraZeneca trial, which is partnered with Oxford, they use a chimpanzee adenovirus. Humans, believe it or not, are not chimpanzees in terms of our immune response. We share other elements, of course. So we would be exposed to the chimpanzee adenovirus. Our human immune system recognizes, oh, foreign invader. It's not going to cause disease, but it is enough to trigger an immune response. When we then take that chimpanzee adenovirus and insert into its genome copies of the spike protein for SARS-CoV-2, then our immune systems, in making response to the chimpanzee adenovirus, also make a response at the same time, simultaneously, to that same spike protein. So it's another way of sort of carrying or injecting the spike protein, which is stable, and is also able to inject and create a full immune response, much as if one were exposed to another type of adenovirus. So AstraZeneca, Johnson & Johnson, the Russian vaccine, several others in China, all use this mechanism. This is a very historic way of giving vaccines, and many others have been used successfully with both safety values, which is significant, and efficacy, which is also significant. Several of the vaccines require two for a booster phenomenon. The Johnson & Johnson or Janssen pharmaceutical is a single injection. They just published, by the way, their data in last week's New England Journal of Medicine. And from the initial studies, they got a 100% antibody reaction to that single injection. They have not yet released clinical data, but every expectation is that their protective value will be so much more significant, even compared to AstraZeneca's. Now, AstraZeneca, this is an interesting little blip in medical history. They're in the middle of their phase 3 trials in the States. They have concluded them in the United Kingdom. The initial data from Oxford suggested that of the two-shot series, if the first injection was half of the intended amount, followed by a normal amount of second injection, that patients who got that construct had a far better immune protection than those who got the two appropriate and normal full doses. Doesn't make sense to anybody except that, number one, the data showing that with sufficiently small numbers that it may represent statistical anomalies, meaning random error, which anybody who is familiar with evidence-based medicine will say, sometimes nature don't make sense, but that's just because it's happening randomly. The other possibility, though, is that despite all the initial studies of the AstraZeneca vaccine to try and find the ideal amount of antigen and adenovirus together to get the best response, sometimes you overwhelm the immune system by giving too much of one or the other, and it sort of down regulates the amount of response. So that may have occurred as well. So waiting to see yet more data from that, and Oxford, I think, is rapidly working on trying to understand and publish, why that may have happened. But as it now stands, it appears that the Janssen single-shot adenovirus vectored vaccine has great potential to be very protective, similar to, and maybe even more so than the current messenger RNA vaccine. So we shall see. Side effects, again, are similar to other vaccines, which is injection site tenderness, the low-grade fevers, the myalgias, the malaise. I think pretty much as with any of the significant vaccines which we now administer for protection, those are the kind of side effects that we'll experience after any COVID-19 vaccine. Okay, the nanoparticle vaccine. This is a newer one by Novavax. It just started phase 3 trials, meaning a large population-based outcome study in the United States and also in the United Kingdom. Here, what the manufacturer's done is taken multiple copies of the actual spike protein itself. So they've already created and synthesized the spike protein. However, if one were to inject just the spike protein in a vial into one's arm, it would rapidly be degraded and eaten or ingested by just a few antigen-presenting cells. So there wouldn't be enough time to trigger a significant immune response. So instead, what they've done is coat or sort of interweave, I guess, the spike proteins with nanoparticles, which themselves trigger an immune response. So it's kind of similar to using a modified virus, an adenovirus, to deliver the spike protein. But here it's a chemically inert, but still immunogenic protein, basically. So these nanoparticles containing spike proteins are injected. The immune system makes its response, and away you go. So yet to be determined how efficacious this is. Similarly with the safety, everything about this vaccine is completely inert, very much like the messenger RNA vaccines. So there are no safety concerns in administering the vaccine to people who may be immunodeficient, immunosuppressed, older ages, etc. So stay tuned for that one. I think it's going to be potentially quite exciting. And then the live attenuated vaccines. So here we're actually taking, or I should say the manufacturers are actually taking an actual SARS-CoV-2, the virus itself, and they're modifying it so it does not cause disease. So making it so it can still potentially express that spike protein and be able to bind, but not take over and kill the target cell. So that's important. There are multiple historic examples of live attenuated vaccines, including the early attempts at the polio virus vaccine. And so the original Sabin and Salk vaccine started with live attenuated virus. Unfortunately, the attenuation process used was not sufficiently robust to keep the virus from evolving to become infectious. So early days, we actually gave people polio in an attempt to try and prevent them from getting polio. The current measles, mumps, rubella vaccine is a live attenuated vaccine. So too is the varicella, the chickenpox vaccine. So in those cases, the virus themselves have been assaulted by chemical toxic environments to get them to evolve so the viruses themselves are not infectious. New to the world then with the live attenuated COVID-19 vaccine is that the SARS coronavirus 2 is injected with, I think it's 23 or maybe it's 24 mutations, which decidedly and distinctly completely prevent its ability to cause disease. So now we're genetically modifying the virus to attenuate it, injecting it. So the human being exposed to this vaccine will make an immune response to the spike protein, which is very protective, but they will also make a response to other antigens or trigger points on the surface, the capsule of the virus itself, which is going to be an even more robust immune reaction, which may be even perhaps longer standing. So the thought is like, give the immune system several targets to make a response to, and take that combined response, which should be even more protective and potentially even longer lasting. So in China and India being tested in the United Kingdom via Codagenics are several of these products. The India product, the Codagenics Corporation, which is now being tested in the United Kingdom, is one of the nasal vaccines. So it's a nasal live virus, which has been genetically modified to be non-infectious. Again, I think there's great hope for that to be significant in its protection. We just have to wait and see. As always, though, there's always the concern of a risk of reactivation. Human nature is fickle, right? We all know that nature abhors a vacuum, and when we mess with something using scientific engineering, there is the potential for nature to mutate back and to potentially even be worse before. So yes, there is that risk of reactivation that has not been demonstrated in the measles, mumps, rubella vaccine. However, in the varicella vaccine, which uses what's called the OKA strain of varicella, which is not known to be infectious, and yet it has been seen to reactivate and cause mild disease in normal recipients. My daughter, for example, got her varicella vaccine when she was 1.5 years old, and she had a mild case of chickenpox from the vaccine. Anybody then who is immunosuppressed, immunodeficient, cancer survivor, solid organ transplant recipient, HIV, AIDS, anybody who has a degree of immune dysfunction potentially is at risk to develop more severe disease from a live attenuated vaccine if it reactivates and if their immune system is unable to make a full response. So these vaccines here will not be indicated for people who are in their older ages, so age 75 and older, as those patients' immune systems start to slow down. It will not be indicated for cancer survivors or current chemotherapy recipients, certainly not for patients with active AIDS or on immunosuppressants. But for the rest of the healthy population, the efficacy should be robust. It should be quite significant. So those are the major vaccine products out there. Obviously, we're all familiar with the impact of Operation Warp Speed to get these vaccines produced, synthesized, approved, and delivered to where we, as you can see in the TMC pod in the lower right, have been administering vaccines at warp speed to people in Tucson. Fantastic. That's great. What are the outstanding issues yet to go? The Food and Drug Administration initially was expecting a 50% efficacy cutoff to approve a vaccine The first two products far exceeded that, 95% and 94.5% respectively, is huge. So what does that mean for herd immunity? Meaning, at what point, at what percentage of the general population, if they are either infected with and or immunized against SARS-CoV-2, can we then anticipate a departure from the pandemic status? Meaning, sufficient people are protected against the virus that it has no toehold and it goes away. Back when the FDA was looking at a 50% efficacy cutoff, the estimates to immunize the entire country required that over 95% of people be immunized. Good luck, that ain't gonna happen. But with the current efficacious vaccines of 95% and emerging disease, believe it or not, it's both a horrible thing and a silver lining good thing that enough people are getting infected right now in this country that we may be able to get by with 2/3 to maybe 75%. That is still a significant number of people who need to be either infected and or immunized against SARS-CoV-2 to drive a true herd immunity approach. And central to that then, because so far we're immunizing just adults, what about a pediatric vaccine approval? The Pfizer vaccine is approved for age 16 and up, so we can get our sort of mid-adolescents. All three trials of Pfizer, Moderna, and now AstraZeneca are starting to recruit 12 years old and up, but so far recruitment for that has been quite slow. So there are hopes to have a pediatric vaccine indication by the FDA by this summer, but again, that'll only be for 12 years old. It won't be for the younger kids. Plus side, though, is that younger kids are not known to be very contagious. So at 5% contagious attack rate versus 12 to 18% for the rest of us. So remains to be seen the impact of pediatric vaccines, but clearly as we start to inform school reentry and work on immunizing our teachers and school staff, also immunizing the kids is going to be another important question. Huge question, and this comes up almost daily. What about the current circulating mutant strains of SARS-CoV-2? What impact does that have on the vaccines? What impact does that have on our testing abilities? What impact does that have on human health? So the current big one, which everyone is I think hearing about from the United Kingdom, is the B.1.1.7 variant. As it turns out, the mutations in the B.1.1.7, and there's at least 18 mutations in that variant, those were first described not in London, not in the United Kingdom, but in Chile. And yet they gained impact. There's a cluster of cases in a community in the United Kingdom, and that's where this current story got its start. Importantly, the B.1.1.7 variant, the other variants currently being described from Africa, and yesterday in Columbus, Ohio, thank you Buckeyes, these variants all have mutations, which the virus is certainly competent to do, but the mutations are insufficient to modify the spike protein's appearance to the immune system. Put into plain English, the vaccines will still work. Our testing constructs will still work because they're all key to recognizing the spike protein, which is not changing in any significant way despite having multiple mutations. What is changing, though, in terms of the variant strains is how contagious they are. And it's yet unclear why that may be, but there are sufficient changes not in the structure of the spike protein, but in how it interacts with its target cells in the nasal epithelium, to being either it binds more strongly, allowing a higher viral load and more a stronger viral presence in the human immune system, or it may bind higher up in the respiratory tree. Meaning that the initial wild type variant, the one from Wuhan, China, caused lower respiratory disease. So it's stuck down in the lower part of the lungs and caused disease there, versus the B.1.1.7 and others, which may be binding higher up into the nasal epithelium, where it's easier for them to aerosolize and to cause disease that way. Both of those are hypotheses. The current evidence would suggest that it's that second hypothesis, the binding higher, which is the more accurate. If the virus were to bind more strongly and have a higher viral load, that should affect all age groups, including pediatrics. And if so, the elementary school children that currently have a very low attack rate should become hyper spreaders just like the rest of us. However, in parts of the country seeing lots of B117, they have not demonstrated that. So it's poor evidence at best, but at least it's a suggestion that the contagiousness of the vaccine, while certainly increased, is not a cause for concern in terms of vaccine response and testing concerns. Also, very importantly, none of the variant strains to date has been found to be any more virulent, meaning they're not causing more severe disease. Yes, they're transferring between patients more readily, causing higher attack rates. Yes, that's true. But those patients getting infected are no more likely to get severe disease than they would have before. And to put all of this into context, I do need to point out that the current global circulating strain of SARS-CoV-2 itself is a mutant. 95% of the current strains around the entire world are the D614G variant, which is also a mutant variant. So what originally came from Wuhan, China is no more. That got competed out and it's gone. So this is where we stand in terms of mutation impact. So far, no predicted negative impact on vaccine efficacy or on our testing ability. And then the safety concerns. Why do we have our 15-minute wait in the cars or the 15 minutes in the vaccine centers? Because we're looking for allergic reactions, and indeed there have been some. A few numbers of patients have had a true anaphylactoid reaction, loss of airway, requiring further intervention. Those are individuals who it seems have previously been highly sensitized to the carrier for the vaccine itself, the polyethylene glycol, and that product, by the way, is present in multiple things which we use, like the toothpaste from this morning's toothbrushing, presumably, and shampoos and things like that. Yet there are individuals in the global population that are sensitized to or allergic to the PEG, to the polyethylene glycol. There are others, however, who have significant active allergic symptoms from other environmental allergies, whether that's pollens or food or what have you. And these are individuals who are indeed developing what appear to be localized allergic reactions to the injection itself. Now, they're responding in many times to over-the-counter antihistaminergic drugs like Benadryl or something like that, but yet it is still cause for monitoring and for concern. Far greater, I think, and this is just my own personal observations, I suspect many of you will support this, the reactions we've mostly seen in the post-vaccination lines have been anxiety-driven. The dyspnea, the hyper-breathing, the I feel weird, and this is not to minimize at all because anxiety reactions are absolutely valid. But I think that we're seeing much more of that as a reaction to the process of getting vaccinated, to the impact of COVID-19 vaccinations than to any true vaccine reaction itself. Neurologic effects. There have been a few reported cases of Guillain-Barré syndrome in patients who received either the Pfizer or the Moderna vaccines. To date, the FDA has monitored those, and as it turns out, the numbers of patients with Guillain-Barré syndrome are no more so than would be expected in the average normal population without vaccination. So the FDA is saying they're monitoring the situation, but they do not feel there's any specific risk from either vaccine product in causing Guillain-Barré syndrome. What about those patients who already have Guillain-Barré syndrome? Should they proceed with vaccination? And the current thoughts are yes, unless they've recently received intervention for the Guillain-Barré syndrome, such as steroids or intravenous immunoglobulin, mostly because those interventions would down-regulate or suppress an appropriate response to the vaccine. Bell's palsy, that is also something which very transient, so very short term, like sort of the drop on the facial nerve, Individuals have developed transient short-lived Bell's palsy after vaccination. So too, those patients who have had a history of Bell's palsy, it's not known to be a contraindication to proceed with the vaccination. Those who do have Bell's palsy after vaccination are monitored expectantly, and they're all resolving spontaneously. So something yet to be monitored. We'll see what happens next. And then finally, concerns about women who are pregnant or attempting to become pregnant, and those who are nursing. To date, the vaccine products that we are administering in this country are all 100% safe. That has been confirmed in small population studies based on both the Pfizer and the Moderna trials. Although pregnancy was an exclusion criteria for both vaccine trials, yet individuals became pregnant during the course of the study, and their outcomes have universally been excellent. So no safety concerns for the women, for the moms, no safety concerns for the babies born to women who were vaccinated, and zero theoretic or scientific risk of expression of messenger RNA or vaccine products into breast milk while nursing. So all those seem to be cause to proceed with normal immunization. So last slide, then we'll open it up for questions. This is actually as of last April. This was a sort of outlook from the CDC, even with vaccination, even with masking, for what the coronavirus, the COVID-19 pandemic may look like going forward. And that there are sort of three proposed models. The top one is the peaks and valleys, meaning that just as with influenza, we will see seasonal peaks and valleys. Oh, it's wintertime, here comes the coronavirus. The middle one is the fall peak, meaning we'll have another huge peak such as we're having right now. And then combination of patients who've been infected and patients who got vaccine, the herd immunity will suffice to sort of slow things down. Versus the bottom one, which is the slow burn approach, and that would be that we'll have continued, small peaks, but they'll be much more mild. Hard to say, obviously, where we're at with these three predictive models. However, just in the last couple of weeks, the combination of the huge attack rate in the United States right now, and also the anticipated impact of vaccinations moving forward as more vaccine doses are released and delivered to injection clinics. The thought is, the hope is, I should say, and it may be evidence-based, that COVID-19 and SARS coronavirus 2 will become no more significant than the annual peaks and valleys of the common cold, such that younger patients will become the ones who have the runny noses and the coughs, and then adults will have mild to no disease whatsoever. So that would mean a disappearance of the hospitalizations, the ICUs, the death rate, etc. I certainly hope that's true. I think it's way too early to tell. But it's clear, though, that we have got to continue with our huge efforts, as we are, to vaccinate as many people as we possibly can to try and get to that point to minimize the impact of the SARS coronavirus 2. So this gets back to the three-act play. We are absolutely in the response part, the Act 3, and whether we are all doomed to die or to do well, I think really depends on our activities over the next couple months. So with that, I'm going to stop sharing my screen and see if we can take some questions here. Oh, and I see one from Dr. Marks. All right, so any issues with pre-medication before vaccine with Benadryl or NSAID? So yeah, this is a great question. The current recommendation, based on no evidence whatsoever, is to not pre-medicate with the non-steroidals. This is sort of the approach which has been shared against other vaccines as well. And the hypothetical concern is that something like ibuprofen, which is a COX-2 inhibitor, will somehow negatively impact the immune response to the vaccine and reduce the immune reaction to the vaccine itself. I've not seen evidence to actually prove that truly happens. Of course, acetaminophen has a completely different mechanism of action, which should have zero impact on the immune system. But there are many who feel that any sort of reduction of the initial fever response to the vaccine is going to somehow de-escalate the immune reaction. I don't understand the rationale for that, but that's the current recommendation. So too with pre-treating with Benadryl. It would make sense that if we can decrease the amount of histamine released by the mast cells, that would make sense. And that should have no negative impact on immune response to the vaccine. It might certainly help in terms of pre-treating for the allergic response. But again, there's been no evidence that I've seen released to really inform that recommendation. Next question, how long do we guess active nasal carriage in a vaccinated person after a given exposure? So assuming, well, I guess two possibilities. So with the injected vaccines, the current Pfizer and Moderna products, the thoughts are just as with a person who has active COVID-19, who actually got infected with, that they may express contagious virus for anywhere from 48 to 90 hours. So we will say maybe up to 4 days after initial infection. That should be true regardless of vaccination or not, because again, the current messenger RNA vaccines are going to have no impact on nasal carriage. So the thoughts are, we'll say 5 days to be a safety zone. The whole reason for isolating somebody who's infected for 10 days is to give at least two sort of time periods, so 2 5-day periods after that initial expression of nasal carriage to where they would no longer be contagious. And that totally makes sense. Let's see here. Just in terms of process, because this has come up just when I was volunteering with the pod, and I'll be back next week. At the end of the day, we do frequently have some doses left over, and of course, the intent is to get every single available dose into somebody's arm. So we have had the practice, it's not a promise, but the practice of vaccinating volunteers who are present if they have not yet. So again, it really depends on availability and how many doses we have left over. Side effects to those who get vaccine after recovering from COVID-19. Is the vaccine actually needed if one has had COVID-19? So great question, and brand new evidence on this from the end of the year from the CDC. The short answer is yes. Those who have had COVID-19 are still encouraged to get the vaccine because if they had mild or even asymptomatic disease, their immune response may be muted, it may not be significant, and it may not be long-standing past 3 to 4 months based on other evidence. The immunity induced by the vaccine, which would be a booster, is going to be quite significant and very protective. You might say, well, but they've already had COVID-19, why get reimmunized? Because the potential for second infections is real. It's not been high, but it could happen, and we don't know what will happen a year from now as everyone's immunity from wild disease may start to lower. The vaccine is predicted to have long-standing high immunity to protect against second infections, hopefully years from now. Obviously, the evidence of science is very young, so we don't know that for a fact. But the recommendation is, regardless of whether one got COVID-19 before or during the vaccine, proceed with the first and second injections. What about side effects from those who had COVID-19 and get their injections? They can anticipate having more of the flu-like illness after their first injection if they previously were infected. But again, this is anecdotal. Those individuals getting their second injections, if anything, had lower symptoms. Several others that I know who developed active COVID-19 right after getting their first injection, they had definite symptoms from the COVID-19, but their second injections went quite smoothly, and they had no more than just the injection site tenderness. So I think that's the current standard as it is to proceed with vaccination. Let's see, from Sheldon. Yes, I will, if it's all right, I will share this PowerPoint with Tim so we can post it for others who may wish, or I don't know if we're recording the current session, but if so, we definitely should be able to release that. All right, so what if somebody's already received either of the messenger RNA vaccines and a newer, better vaccine offered? Can we give that additional vaccine? It's a great question. My thought would be yes. This is based on very early evidence from the United Kingdom where they are crossing or mixing the vaccine doses. For example, individuals in London who received a first Pfizer vaccine, messenger RNA, are now being given AstraZeneca vaccine, which is the adenovirus vectored. So it's two different ways of presenting the same spike protein, two different ways of triggering different elements of the immune response system, which actually, to my mind, would make it even more robust approach to vaccine protection. So my thought would be, should new vaccines come along which have added or different benefit than the current vaccines, and should there be some sort of lessening of protection from the current messenger RNA vaccines, it makes a lot of sense to proceed with vaccinating with other vaccines. Heaven knows what will happen in the future. That's something to be determined. So if dexamethasone is used, is the intramuscular route okay? Can they go home and take it there without needing infusion? Boy, I don't know how to answer that. I mean, I think the dexamethasone is going to have an impact on immune response regardless of the injection or administration route. So, boy, I think we'll just have to sort of see what happens in terms of the science for that. My thought would be that the immune reaction is going to occur regardless, mostly because the steroid impact is a different element of the immune response. It's more typically going to be macrophages and not the other antigen-presenting cells. So I would think the impact of dexamethasone use should be tiny. This is theoretic and not based on science, but it should be tiny based on however we choose to infuse or inject somebody. So from Mary, yes, please review the recommended PPE for volunteers working at the pod. So currently, what we wish to do is to protect ourselves from vaccine recipients driving up or coming to the clinics, which is going to be the surgical masks, which is currently adequate, and the face shields or the eye goggles. So we're trying to prevent acquisition of those droplets within 3 feet into the mucosal surfaces, i.e. nose, mouth, and the eyes. And as those of us who've done vaccines, and as we lean into the car windows, we're getting close and personal, within 3 feet for sure, the vaccine recipient. However, wearing of the gloves to do a mass immunization outreach, such as we're doing at the pods, is not necessary, is not indicated. And that this is both based on safety response and also CDC and national criteria. So the flu vaccination clinics, certainly the COVID vaccination clinics, we do not need to be wearing gloves in between. We do, of course, need to be cleaning our hands between our vaccine recipients. And so the alcohol-based hand gels, and when that builds up, there are water stations in place to sort of get the hands clean. What is an oral dose of prednisone that is helpful? So it appears, again, because quantity is everything, what has been found anecdotally in the hospital setting to be useful is the 2 milligram per kilogram per day, typically divided BID, twice a day. That is quite robust. That is for, I'm going to say, normal and air quotes severe COVID-19. In my world, I deal with a fair amount of pediatric MISCI, which is the multi-system inflammatory syndrome in children. Those are patients in whom we're either doing with intravenous Solumedrol at 2 milligrams per kilogram, or even if they have cardiac dysfunction, which is about half of them, we are whacking them over the head with up to 30 milligrams per kilogram per day. So this is a high dose pulse steroid, and then they're on a 3-week tapering course after that. So it is significant. For those patients, however, who have known reactive airway disease or are asthmatics, the usual 1 to 2 mg per kg per day dosing of prednisone seems to be adequate. The challenge is to do it longer than the usual 5-day course. Here's a question about the blood types that seem to have some protective value. This was evidence emerging early in the pandemic, and that still does appear to be true, although the hypothetical reason why is yet to be confirmed. So it appeared that people who were type O we're less likely to have severe disease and potentially to even be infected in the first place, while those of us, self-included, who are type A blood, we're more likely to get disease and more likely to have severe disease. The reason for that is that the ABO transferases, the genes encoding those, are located on the chromosome very near to one of the sites for expression for ACE2, the acetylcholinesterase 2, which is the receptor for the virus. So it may be that those of us who are expressing our type A transferase, who are type A positive, that may have a downstream permissive effect on upregulating ACE2 receptor expression, meaning that there's more available target for the virus to bind to, higher viral load, higher disease, higher risk of disease. That still seems to be true. It's not been confirmed yet in the animal studies that I've seen, but stay tuned for more. We shall see. Every week, by the way, there's new evidence which either adds to it and or completely addresses or changes something which was thought before. So as I write a biweekly blog, I'm like, so unlike I reported previously, now the science would suggest, and it just changes. Next question, is there any discussion of giving priority to the vaccine for family members living in a household with a COVID positive person? I've not seen that come through the priority discussions. Of course, the need is so incredibly overwhelming that I think that degree of granular detail has not yet been discussed. Instead, the thought seems to be to try and immunize anybody who is susceptible or more highly susceptible to severe disease, regardless of exposure potential at home. So the current 1B priorities, including those who are 75 and older, would seem to address that. My suspicion is, as we get more granular by healthcare providers bringing their patients in to get vaccinated, that they will prioritize those who have immunodeficiencies, those who have chronic lung disease to be prioritized to get vaccine over the general public who may be otherwise healthy. But I'm not aware of discussions occurring at any sort of national or investigative level. If a patient receives steroid treatment per vaccination, should they wait a certain time before vaccination? Should they wait a certain period of time before receiving vaccine? Again, as I was commenting on for dexamethasone, my suspicion is no, that they can proceed. I will say as a caveat, though, somebody who's receiving steroids likely is doing so for a reactive airway disease or something triggered by a viral infection. At least currently, that's what triggers a lot of our pediatric asthma patients. If that's the case, that they need to wait at least until they're asymptomatic plus a couple days, so that A, they don't, provide being contagious to our vaccinators in the pod, and B, if they're actively infected with something else, even including SARS-CoV-2, their response to a new antigenic challenge from a vaccine is going to be downregulated somewhat. That's that whole immune system sort of positive and negative balancing act between the two elements of the immune system. So my thoughts are someone who's currently on steroids for a infection or symptom-induced wheezing episode needs to wait until they're off the steroids, simply to give time to recover from that initial process before coming for vaccine. All right, what evidence is there that statins help reduce the risk of disease severity? So, boy, this is one of the many elements of sort of non-anti-infective interventions that's been looked at. And the evidence, I think, has been all over the world. It's not been conclusive, mostly because the studies looking at use of statins have had a wide range of patient inclusion. So it's hard to identify a specific risk category that might benefit or might not benefit from statins. Great question, but yet no data to give an affirmative answer to that. Back to the blood type questions, what about type B? I've not seen specific numbers. I mean, the comparisons were between type A and the type O. So of course, the poor type Bs are left out in the cold. Sorry about that, y'all. My thought would be that they likely have no higher risk than the type Os. It really seems to be something about the turning on of the type A transferase, which continues that risk of increased disease. So if you're a type B or a type O, salud, congratulations, you're in good shape. How about the 4-day plus or minus? Can we comment on longer than 3-week or 4-week second dose? Is it just as effective once received? Yeah, boy, that question is critical because it's at the center of the release of the national stockpile of doses to everywhere right now. Obviously, there have been stockpiling trying to protect vaccine to be delivered at 3 weeks out or 4 weeks out, which meant or means that a fair number of people who haven't yet received their first dose are being sort of pushed back. It seems without any evidence that the response of the immune system after 3 or 4 weeks is going to still be sufficiently robust. That the problem is that there's no long-term data to prove that. It hasn't been tested. And of course, nobody wants to go out on a limb to say, hey, this is okay, let's go for it. So instead, that they're doing the 4-day window plus or minus as a safety precaution. My sense is, since the initial recommendation for people who got their first injection got infected and then were told to wait for 2 months, that there is some element of further wiggle room than just plus or minus 4 days. How long that might be, nobody's willing to comment on. My sense would be we actually have several weeks of wiggle room because the initial B cells that are being created and immortalized by the first injection are not going to go away. What's going to happen with the second injection is to recruit more of them, to increase the numbers. So that should still happen even if we're waiting several weeks out. The rheumatologic biologicals, so here we're looking at sort of like the anti-interleukin 6s, the anti-TNF alphas, a couple others. Those actually continue to have evidence rolling out in a steady fashion to support their use in those who are already critically ill. So specifically the interleukin 6 monoclonal antibody, tocilizumab, if I'm saying that correctly, that does seem to have positive benefit in those patients who are already in ICU on ventilator, and it's reducing their length of time on ventilator and their length of time in the ICU. How much more is out there? What other products are being tested? Again, these are small case studies that are being brought out, and nothing huge recently published that I've seen, but who knows what the future looks like. And then what about comments about future autoimmune diseases and potentially triggered by or somehow released by use of a messenger RNA virus vaccine? You know, I guess it's a theoretic risk, but there's nothing about the response to the messenger RNA that should being the key word, trigger a risk for autoimmune diseases down the road. Is it simply just letting antigen-presenting cells react to messenger RNA in a very limited, specific fashion? It's a very short-lived response, and no immune system should be immortalized with any autoimmune process. Theoretically, however, one could think that there may be some crossover reaction to some nuclear material expressed by the antigen-presenting cell. So one can actually have an autoimmune targeting of the monocytes or the dendritic cells. Theoretically, I guess that makes sense, but at least in the animal models and in studies of messenger RNA vaccines, which has been going on actually not for months, but for a decade or more, there is no evidence of that occurring in the primate model or in the in vitro model. So, you know, I'm never want to say never to nature, but I think that risk is theoretic at this point and no more. So, oh, I see. So the question from Dr. Cantrell. So for the room drugs, not as therapy, what about people already on them? So people on we'll say monoclonal antibodies against interleukin 6 or TNF alphas, whatever, that should not have any impact on the response to the messenger RNA vaccine. There may be a theoretic risk in response to the adenovirus vectored vaccines, but those are individuals who would be considered immunosuppressed and would not be candidates for potentially the adenovirus factored vaccines. Certainly for the live attenuated vaccines, they should not receive those. But at least the messenger RNA vaccines should be safe for somebody who's on a room drug at this point. They won't develop disease. They may just not have as significant a vaccine take as we would want. And then what do I say to people who are afraid of the vaccine? Can be, I hope this is tongue in cheek, can there be covert aspects of the messenger RNA? Yes, we had this great discussion one of the days in the pod about where the military's probe was situated after we injected, and we thought it was like the bridge to the nose, you know, because so the tinfoil hats don't protect you from that. All right, so tongue in cheek aside, what do I say to people who are afraid of the vaccine? We have to find out where their concern is. Is it just a general, I don't trust medical science? Well, that's a bigger conversation. Or is it concern about the novelty of the vaccine itself? And to those individuals, I would point out the inert nature of the vaccine, the fact that this vaccine type is not brand new, that the science behind this is over 10 years old. And it has been thoroughly safe and effective. There was just never a significant reason to escalate discovery of these vaccines to the point that we currently see. So, it's a great question. I would just have to understand where their point of disconnect was, and then try and address that with science. All right, I think that is a list of questions, everyone. Thank you all for your time and attention. I think we're just about done. Mary.
Thank you, Dr. Elliott. Unless there are any additional questions, we are a little bit early. Thank you very much. And I want to remind everyone about the upcoming next Saturday, January 23rd, pod training. That's for new people, directed to new people, but obviously anyone, even if you've attended that particular training before, is welcome to attend again. We will be updating as much as possible, infusing into that particular training any specific tips and pieces of information that we have that's pertinent to the content relating to our current pod and how things have been working. As you know, every day brings something potentially new and of concern that we need to address in terms of questions and so forth. So ongoing, this is a work in progress. And again, I invite you to do that. Tim, would you like to provide some closing comments and any other information that you might have on your list? Tim seems to be in the room, but maybe not fully available. So unless there's anything else from anyone, we will adjourn for today. Again, many thanks to Dr. Elliott for that very enlightening talk. And I wish you all well. I look forward to seeing you at the pods and at future trainings. Thank you.
Thanks, everyone. Have a great day.
Thank you.
Thanks.